So this session is titled Fertility When Living with Sickle Cell Disease, Exploring IVF and Other Options. You will have tons of opportunity to learn a lot about this topic, but to moderate this particular session, we are honored to have Dr. Dana Powell with us. Find her page again, because there's tons of eloquent speakers here. But Dr. Dana Powell has a strong academic and research background with over 16 years of experience in several therapeutic areas, including hematology, hepatology, gastroenterology, oncology, and biology, and more ologies and ologies. She completed her PhD at the University of Toronto and then went on to pursue a medical degree at St. George's University School of Medicine. Dana has also completed 2 postdoctoral research fellowships at the University of Toronto and the Hospital for Sick Children, where she further published several scientific research articles in the field. Dr. Dana is currently a medical strategist and utilizes her strategic thinking, strong medical and scientific expertise to make a difference in the healthcare marketing space. She joined SCD Board of Directors over 5 years ago and has been a long-standing advocate for the sickle cell community, and she has represented SCD at community events and is a fearless proponent for driving increased awareness and education. Please help me welcome Dr. Dana Powell.
Awesome. Thank you, Chloe, for that lovely introduction. Good afternoon, everyone. And we're super excited that after you've all eaten, so everyone's bellies are happy, right? Yeah, I see some smiles. Awesome. So now that you're all in a good mood, we're going to introduce you to the afternoon patient community track 2 session. And we're going to be talking about fertility when living with sickle cell disease, exploring IVF and other options. And it is my pleasure and privilege to introduce to you our speaker today. It's the lovely Dr. Kristine Matusiak. I practiced this, I promise I did. I think I got it right, I got a nod. And she is a benign hematologist working in the hemoglobinopathy clinic at Hamilton Health Sciences. She has specialty training in obstetrics, hematology, and an interest in women's health issues for patients with sickle cell disease. So please join me in welcoming Dr. Matusiak to the platform, and we're in for a treat this afternoon. Thank you.
Thanks, Dana. All right, thank you for having me. I'll just make sure this is working. So I have 2 main objectives today. First is to discuss what we know about issues relating to fertility for patients with sickle cell disease, and then to review also what we know about fertility preservation as well as assisted reproduction in patients with sickle cell. My main disclosure is that I am not a fertility specialist or obstetrician. So I have gone to the literature as a hematologist, as somebody who's interested in sickle cell, and tried to understand what we know about fertility. So I am doing my best to answer any questions, but I'll definitely take down any that I don't know the answer to and would be happy to consult with some more esteemed colleagues in fertility if I can't answer your questions. So we're talking about fertility and reproductive health in sickle cell disease because we've made advancements in sickle cell disease such that patients can now make it into adulthood with fewer comorbidities, with improved quality of life, and hopefully that means that they have more opportunities to engage in the types of social activities and educational and career activities that allow for the opportunities to expand your family. So this is incredibly positive, but now we've arrived at the doorstep of asking what now and what are the fertility issues that patients face when they get to this stage in their life. And I think I forgot to mention that in my disclosures that Dr. Verhovsek is talking specifically about men's health issues later today, so I'm focusing primarily on women today. We know that women with sickle cell are susceptible to the same fertility issues as the general population. So that includes things like aging and ovarian reserve decline with age, which is a common fertility issue as women are more present in the workforce, but also structural and male infertility issues. But on top of that, there appear to be some disease and therapy-specific risks. And importantly, there is no definitive study about infertility or the true definition of fertility in sickle cell. So nothing that's followed patients forward and looked at fertility rates, but we have some evidence about markers of fertility. Importantly, there are high rates of self-reported infertility among women with sickle cell. So what we hear from the population is that they do have higher rates of infertility. We just have not quantified that in a large data set. So let's start first about the window of fertility. Girls with sickle cell have a later onset of menstruation, so up to 2.5 years later than girls without sickle cell. And then women go into menopause up to 4 to 5 years earlier. So we know that that window of fertility, just looking at these statistics, is smaller. And then there's a lot to learn and understand about ovarian function and some of the markers of fertility that have to do with the ovaries and the follicles they produce. So the ovaries are an end organ, just like any organ that is susceptible to sickle cell damage. So certainly some of the expected changes that we see in any other end organ are possible in the ovary. One of the common measures of ovarian function or fertility is something called the anti-Müllerian hormone, or AMH. So this has been long used as a biomarker for ovarian reserve. If you measure AMH through the lifespan, it goes down as women approach menopause, and it's a surrogate marker for fertility, or one of them. We know that there appears to be an accelerated decline in AMH among women with sickle cell. So you can see in that graph there, the red dots are women with sickle cell compared to controls, and so they're starting lower and progressing downward at a faster rate. Anti-Müllerian hormone is sometimes used with other markers, some imaging markers where they're looking directly at the eggs in the ovary, but also other hormonal markers to quantify or qualify something called diminished ovarian reserve. And diminished ovarian reserve has also been identified in women with sickle cell at pretty alarming rates in young women. So up to 25% of women with sickle cell under 31 have been diagnosed with diminished ovarian reserve based on some of these markers. And that's important because in the general fertility world, diminished ovarian reserve is predictive of response to fertility treatments, and is sometimes considered an indication to consider fertility preservation. So if you're diagnosed with something like this early in life, it might be worth considering preserving your fertility, which we'll talk about those processes in a moment. In these studies looking at women with sickle cell, there was an association between diminished ovarian reserve and hydroxyurea use, and I'm going to talk about that in a bit more detail in a moment. And importantly, as I said at the beginning, we don't have a true study looking at fertility or infertility and sickle cell. So these are markers, but they have not been definitively shown to be predictive of fertility in sickle cell. They're suggestive, though, so we've got questions that we need to answer. Please stop me if there is anything that I say that's too clinical, or I'm happy to stop. I did want to talk about hydroxyurea. So obviously this raises a lot of eyebrows. This is a drug that many people are on and is very widely recommended. So I think the bottom line here is that we don't know if hydroxyurea causes diminished ovarian reserve or if it's a proxy for other sickle cell associated risks for diminished ovarian reserve. So we don't know if the direction goes hydroxyurea to that DOR or if some common pathway that causes complications of sickle cell is associated with hydroxyurea use. Perhaps more severe phenotypes are offered or treated with hydroxyurea and also cause diminished ovarian reserve. And so this is a really important research question to be answered. It's a really important question that we all need to think about because we have a lot of evidence for the benefits of hydroxyurea, including the benefits of reaching adulthood with fewer comorbidities and fewer pain crises, the things that allow us to think about exploring our reproductive health. So definitely something to think about, but is not a causal connection at this point. I wanted to talk about some of the other therapies that we often use and maybe what we know about their connection to fertility. I think really importantly is to start at square one. What do we know about untreated sickle cell? We know that there appears to be this association with accelerated or decline in AMH, not to mention some of the other things I mentioned about comorbidities. So that's option one, is untreated. Disease-modifying therapies, I've talked about hydroxyurea, and I did want to mention also that whenever we think about these therapies, we should think about how they apply in pregnancy, and we avoid the use of hydroxyurea in pregnancy, so there would be interruptions of care. Red cell transfusion, some of our patients are on chronic transfusion or perhaps had chronic transfusion as a child. It doesn't appear that there is a large population of patients who end up getting iron deposition. So iron overload is one of our complications of transfusion. Iron deposition in the pituitary gland, which is kind of the homing device for how all of our hormones respond and generate our reproductive hormones. There doesn't seem to be a signal that there's a high rate of iron deposition there. But there theoretically could be iron deposition in things like the ovaries or the follicles. And then, of course, we know that chelators are also contraindicated in pregnancy. Many of our other treatments, no data. We have no idea what things like crizanlizumab or voxelotor do in fertility. I think really important is to speak about curative therapies. So stem cell transplant becoming increasingly available, certainly offered in pediatric patients, prepubescent patients. And we have a reasonable amount of data because stem cell transplant's been used in cancer populations that the conditioning regimens, which are the chemotherapies and radiation regimens used to prepare the body to receive stem cells, are associated with infertility. And so certainly in the cancer world and in stem cell transplant and soon to be gene therapy and sickle cell disease, these would certainly be reasons to consider fertility preservation or to offer fertility preservation to patients who are going to be exposed to these. So before I keep going talking about fertility preservation and IVF treatment, but I wanted to just step back and think bigger picture here. So important to think that when anyone is thinking about growing their family with or without sickle cell disease, there are many ways to do this and there are many things to consider. So, you know, the general groupings would be thinking about natural conception, thinking about assisted reproduction, thinking about gestational carriers or surrogacy. Both of those last two involve either using your own eggs and sperm or donor eggs and sperm. And then, of course, thinking about adoption. And these things are personal decisions. They are affected by sociocultural expectations and norms, very important in this population, and there are medical reasons why you might think about one option over the other. And as we know, fertility treatment is not free, so financial considerations, not to mention the financial implications of having a child, are also important to consider. So many things to think about when you're thinking about as a patient, but as for your provider to be counseling about. So just some definitions so we're clear about some of these things. In vitro fertilization, which I'll go through the process in, I think, on the next slide, is manually fertilizing eggs with sperm in a lab setting, allowing that to incubate and hopefully grow into an embryo. That embryo can then be transferred directly to a patient or frozen for transfer later. And that embryo can be subject to certain testing, which we can talk about. Artificial insemination and intrauterine insemination are both processes that involve transferring sperm into either the vagina or further into the uterus, which is just usually helps some of the hurdles associated with more of the structural issues or sometimes chemical issues in getting pregnant. And fertility preservation involves freezing sperm or egg samples to be used later, to be used together to create embryos and then frozen for later, and then used either if it's a sperm sample to be used for artificial insemination or if it's an embryo to be transferred in an IVF procedure later. So a little bit more about IVF. As I said, this involves taking an egg and sperm and putting them together in a lab. How do we get those samples? So in a woman, it's a little bit more involved than the male donation, as you can imagine. So in a woman, that involves using hormones to stimulate the formation of extra eggs or extra follicles in the ovaries than you would normally produce in a normal cycle. So they're kind of hyper-stimulating that production of eggs. Then at the right time, based on ultrasounds and hormones, they do a procedure where they go and collect the egg. So that's a transvaginal procedure. It involves a needle, and it's an uncomfortable or painful procedure. Those are then subject to that IVF incubation, where they combine it with a sperm, watch it for growth to become embryos, and then it can be either transferred directly, which is a pretty simple procedure, just injecting that with a catheter into the uterus, or frozen for later to transfer later. So what are the sickle cell specific issues around this procedure? The egg retrieval procedure itself is painful and has been reported to be a trigger for pain crises. So extra care and management around pain management is important there. The actual stimulation is hormonal. So we're giving hormones to stimulate these eggs. Those hormones are things like estrogens, which increase the risk of blood clots. And patients with sickle cell are at already increased risk of blood clots. So there may be an increased risk around that time, particularly if the hormones go overboard. There are some complications of this procedure called ovarian hyperstimulation syndrome, which is a very high risk period for blood clots. The hormones, oh yeah, go ahead. Are they what? Are they also injected hormones? Yes. Yes. So if you want to freeze your eggs, you're going